Let's jump right in. Welcome, clinical colleagues. No fluff today. We are doing a rapid cold open straight into the high yield kinetics of pulmonary obstructive disease management. If you're aiming for that master level understanding of respiratory pathology, well, you're exactly where you need to be. Let's start right at the inflammatory baseline of obstructive airway diseases.
So let's think about the absolute pathological foundation of asthma. By definition, it's an entirely reversible IgE-mediated hyperresponsiveness. But honestly, the most crucial word here is inflammation. Because it's fundamentally an inflammatory process, the absolute baseline for any persistent asthma simply must be an inhaled corticosteroid, or ICS. We aren't just putting a Band-Aid on bronchospasm, right? We're actively treating that underlying inflammatory cascade. If your patient is having symptoms more than twice a week, an ICS is the mandatory starting point, no exceptions.
And you can see how this builds perfectly into the modern stepwise treatment pathway, what we call the SMART paradigm. For those intermittent symptoms, step 1 is just your short-acting beta agonist, your SABA like albuterol, used purely as needed. Step 2 brings in that low-dose ICS for daily control. But step 3, that's where advanced maintenance really kicks in. Here, we're utilizing an ICS combined with a long-acting beta agonist, a LABA. Actually, modern protocols heavily favor a rapid-onset LABA like formoterol, precisely because it acts as both a daily maintenance controller and an acute rescue inhaler, all in one. It's incredibly elegant. Now, we absolutely have to talk about a persistent high-contrast warning. This is a definitive management rule you cannot miss. LABA monotherapy is completely, absolutely contraindicated in asthma. Using a LABA like salmeterol all by itself without an inflammatory controller like an ICS sets up a literal lethal paradox. The LABA just masks the symptoms of the bronchoconstriction, while underneath it all, that airway inflammation is silently accelerating. It's a setup for sudden, catastrophic status asthmaticus. You must never, ever prescribe a LABA without an ICS in an asthmatic patient. It drives a massive increase in mortality. Okay, so shifting our clinical focus just a bit, the crucial point is recognizing the stark difference between reversible and irreversible disease. We have to contrast asthma with COPD. Asthma features that reversible hyperresponsiveness we just talked about. COPD, on the other hand, is defined by completely irreversible alveolar destruction, like we see in emphysema, along with the chronic remodeling of chronic bronchitis. If we were looking at some luminescent flow volume loop overlays right now, asthma would show this variable obstructive pattern. But COPD, it presents that classic, fixed, scooped expiratory phase that doesn't meaningfully reverse at all, even with bronchodilators. And radiographic reality perfectly illustrates the point. When you look at severe parenchymal changes, you're literally seeing irreversible destruction in the lung architecture. That classic honeycombing, the massive bullous changes, this physical destruction absolutely dictates our management limitations. You simply cannot pharmacologically reverse missing alveolar walls. So our entire management strategy has to shift away from trying to reverse the disease and move entirely toward mitigating symptoms and slowing that inevitable decline. Which brings us to a highly surprising but very testable fact. Standard inhaled therapies, your LAMAs, your LAVAs, your inhaled corticosteroids, offer absolutely zero mortality benefit in COPD. Literally zero. Now, don't get me wrong, they are fantastic for reducing symptom burden, improving exercise tolerance, and crucially reducing how often acute exacerbations happen, but they do not actually prolong the patient's life. So, if inhaled therapies don't save lives, what actually does? Welcome to the survival matrix. There are exactly 2 primary medical interventions that definitively prolong life in COPD. Just 2. First up is smoking cessation. This is literally the only intervention proven to slow the age-related decline of pulmonary function. The second is long-term oxygen therapy, or LTOT. As a clinical consultant, you've got to lock this in. These are the only true mortality modifiers in our entire arsenal. But LTOT isn't something we just hand out casually. There are strict, highly testable physiological thresholds that mandate it. You're prescribing LTOT if the patient's resting PO2 is less than or equal to 55 millimeters of mercury, or if their oxygen saturation is 88% or lower. But keep in mind there's one vital exception to those numbers. If their PO2 is 59 or lower, but the patient already shows evidence of end organ damage from chronic hypoxemia, specifically we're talking cor pulmonale or polycythemia, then LTOT becomes absolutely mandated. Let's escalate the clinical tension into acute exacerbation management. Say a patient comes in, severe distress. You immediately hit them with supplemental oxygen, inhaled bronchodilators, and systemic corticosteroids. But watch out for the hypercapnic threat.
if that patient develops severe respiratory acidosis, and we're strictly defining that as a pH less than 7.35 and a PaCO2 greater than 45, the absolutely mandated next step is non-invasive positive pressure ventilation, BiPAP. You use NIPPV to decrease the work of breathing and blow off that CO2, actively bypassing the need for immediate intubation. Furthermore, during any COPD exacerbation, you always have to assess for the antibiotic trigger. You don't just throw antibiotics at every wheezing COPD patient, right? You introduce empiric antimicrobials like azithromycin only if very discrete criteria are met. The strict requirement here is increased sputum purulence, and that must be paired with either increased dyspnea or increased sputum volume. If those cardinal symptoms are present, empiric coverage isn't just an option, it's mandatory. Let's synthesize all of this into a clinical variance box, directly contrasting exacerbation management based purely on the underlying pathology. For refractory bronchospasm, acute asthma absolutely demands IV magnesium sulfate, whereas COPD leans heavily on inhaled anticholinergics like ipratropium. And for hypercapnic respiratory failure, well, as we just established, COPD mandates NIPPV. But an asthmatic in hypercapnic failure who is fatigued, that is a completely different story. That requires immediate intubation. The clinical response diverges drastically here, and confusing the two can literally be fatal. Which brings us to the master case. I'm going to challenge you here to integrate everything we've covered against a masked, catastrophic physiological transition. We've got a 24-year-old female presenting with severe status asthmaticus. We need to determine the exact, immediate next clinical step as her presentation evolves. Let's trace her timeline. Pay really close attention to her clinical evolution here. On arrival, she's breathing at 35 breaths per minute using accessory muscles. Her ABG shows a PaOCO2 of 28 millimeters of mercury. Now, this is totally expected, right? She's hyperventilating, she's blowing off CO2, and that's putting her into a respiratory alkalosis. We hit her with immediate aggressive treatment, albuterol, ipratropium, and IV methylprednisolone. 2 hours post-treatment, her respiratory rate drops to a nice, comfortable 16 breaths per minute. Her PaCO2 is exactly 40, her pH is 7.38, and her chest sounds quiet on auscultation. Okay, stop right there. This is the crucial point, the diagnostic trap. You look at those numbers. A respiratory rate of 16, a perfectly normal PaCO2 of 40, a pH of 7.38. It is incredibly tempting to diagnose clinical improvement. But I am aggressively warding you against this. In an actively asthmatic patient who is just hyperventilating, these normal numbers are utterly terrifying. They signify catastrophic diaphragmatic exhaustion. Let's evaluate the exhaustive option matrix for your next clinical step. Option A, hospital discharge. This is the lethal trap. You are misinterpreting exhaustion as improvement. Option B, administer IV magnesium. Look, while we use it for refractory bronchospasm, it is vastly insufficient right now because this patient is an impending respiratory arrest. Option C, transition to NIPV or BiPAP. Unlike in COPD, applying BiPAP to a late-stage, severely fatigued asthmatic is totally contraindicated and inadequate. They simply lack the muscular endurance to trigger breaths against that high airway resistance. Option D, continue current observation. This will lead directly to anoxic brain injury or death within minutes. Therefore, option E, immediate endotracheal intubation, is absolutely mandated. That quiet chest, it doesn't mean the bronchospasm magically disappeared. It means the patient is so fatigued and so clamped down that there is literally zero air movement. You absolutely must secure the airway mechanically. I want to leave you with this provocative thought. When does a perfectly normal lab value actually signal impending death? The takeaway here is to never look at a lab value, like a PaCO2 of 40, in complete isolation. You've got to integrate the complete physiological reality of the patient right in front of you. A normal number in a hyperventilating patient means the respiratory drive has completely failed. Thanks for joining me on this deep dive today. Stay sharp, trust your clinical integration, and I'll see you in the next explainer.